Well, hello everybody, and welcome to the third grand round of Great Ormond Street 2020 series. And thank you very much for coming back, making this series the most successful so far. Last week, we had 457 participants, which is by far the most we've ever had for a grand round, and some of that it's fantastic. So we are going to hear from the infectious disease team, which are going to tell us a little bit more about COVID and the story in children so far here at Great Ormond Street Hospital. You can self-credit CPD points for this. And we've been told by the RCPCH that you can self-credit 1 point, which is 45 minutes worth of learning and 50 minutes of self-reflection. Okay, so I think we'll move on. And what I'll do is I'm going to introduce Karen in a minute to then introduce her team who are going to do the presentations for us individually. So it's a great pleasure again to introduce Karen Moshall, who's going to chair her department's grand rounds today. As you know from last week, Karen's a consultant in infectious diseases, and she's been so at Great Ormond Street for the last 17 years. But it's worked all around the world, as well as in London, South Africa, America, and in 2004 founded an NGO in South Africa called Chiva, which is looking at the response to the pandemic of HIV in children in South Africa. And to date, that has trained over 20,000 people in a response to the pandemic. So she's well qualified to talk about a pandemic and the training response that we have as a healthcare profession. So without any further ado, I'll put you on to Karen, who's going to introduce today's talks and introduce you to the speakers.
Thank you very much, Jonathan, for that lovely introduction. Welcome, everyone, and thank you for being with us to hear our story as it continues. As with any new disease or emerging disease process, it's a challenge to recognize the patterns of disease in the clinical presentation as they emerge in real time, and then use that information to define the clinical syndrome and then refine the case definition. So wherever in the world children are presenting with that clinical syndrome, the healthcare professionals looking after them have the ability to recognize them in a timely fashion and treat them appropriately. Making a link between the clinical syndrome and a common underlying cause is very complex and is dependent on robust diagnostics to make that link, which in itself is a huge challenge to develop. Finally, understanding the epidemiology and the pathophysiology, defining the vulnerable patient groups, and developing optimal treatments is reliant on gathering good quality evidence. Our program today is a reflection of this process. We're going to start with a clinical overview of this new and emerging syndrome from Alistair Bamford. That will be followed by a clinical presentation from May Johnson, who will discuss our PICU experience. Following that will be Kimberly Gilmore, who will be talking about new diagnostics that have been developed in response to this new disease process. And finally, we will be looking at the research studies that have either started or will be started very shortly in Great Ormond Street. Those will come from Louis Grandjean, Mark Peters, and Joe Standing. So without further ado, I will hand over to Alistair Bamford. Alistair, over to you.
Thank you, Karen. So I will start this part of the presentation, which is mainly covering an overview of a newly emerging syndrome, which we've become aware of over the last 3 to 4 weeks in the UK. Last week, you heard us talking about the more classical presentation of a child with respiratory COVID. But we found more and more over recent weeks that there's a new manifestation in children that seems slightly outside what we've seen in adults. This has been termed pediatric inflammatory multisystem syndrome, temporarily associated with SARS-CoV-2, a very catchy name that we've abbreviated to PIMS-TS for now, while we're trying to characterize it. So how did this come to be? Well, on the 25th of April, which seems like a year ago now, but it's actually only 2.5 weeks ago, we noticed that across the South London network, in collaboration with the South Thames Retrieval Service, that there were children presenting with shock without any known infectious cause to that shock across the South London region. And they had 3 children in the space of 24 hours on the background of some cases in the preceding weeks. In the same weekend, we got an alert from the CATS team of a similar 3 children in the space of 24 hours with this presentation of shock with no culture positive. And so this was enough for us to notify NHS England through the Paediatric Intensive Care Network to arrange for there to be an alert to relevant clinicians throughout the London region and nationally to be on the lookout for this emerging syndrome, which was and is still rare in children nationally. As a result, as part of that piece of work, we looked at a series of 37 patients across the UK, mainly from the London region, to try and work out a case definition, which is the first step in characterising a newly emerging phenomenon. And then that can be used to inform surveillance and crucial research studies to characterise it further. We looked at these cases from across the UK, and as you can see, they were mainly in PICUs in centres of the UK where there have been higher rates of SARS-CoV-2 compared to perhaps other centres, places in the UK. And if we also looked at the emergence of this phenomenon in relation to the emergence of COVID in cases proven in the country. And you can see in the blue line, which is on a different scale to the yellow line of our cases, that as this phenomenon seems to have emerged 2 to 3 weeks after the PCR confirmed cases in adults in the UK, suggesting that it may be temporally related and may also be pathologically related to the emergence of SARS-CoV virus. We have the data available, but unfortunately I can't show you the fine detail of the data because it's been submitted for publication and is under review. However, I can highlight that from the 37 cases that we looked at in the UK, the most common clinical findings, and these were present in over 50% of the patients each, were fever, which was present in 100%, shock, diarrhea, abdominal pain, and rash. Which are pretty non-specific features, but they seem to come out as common features in most of the cases we looked at. And similarly, there's been some common laboratory findings. And these are all present in over 75% of the cases we looked at, with anemia, neutrophilia, high ferritin in the range of 2,000 to 3,000, low albumin, raised D-dimers, very high CRPs in the 200, 300 range, raised troponins. And these characteristic blood findings are very similar to that which is seen in severe SARS-CoV infection in adults, which raised our suspicions that it may be related to SARS-CoV-2 as well. And just to highlight at the bottom there that only a minority of patients had PCR-proven SARS-CoV-2 infection from multiple specimens. And subsequent to this analysis, and during the analysis, it's become apparent that the majority of children are SARS-CoV-2 IgG positive, so indicating exposure to the disease at some point. Kimberly Gilmore will talk a bit more about this later in the grand round. We should note that some of these children have received IVIG, and Kimberly will also talk about this in her the implications of this in her presentation. Cardiovascular involvement seems to be a prominent finding. As I mentioned, shock requiring inotropic support in 70% of children, myocardial involvement, including echo abnormalities, ECG abnormalities, or significantly raised cardiac enzymes in over half, coronary artery involvement in a minority, but some significant coronary artery dilatation in a minor proportion, and 3 children required ECMO. And compared to adult studies, the need for respiratory ventilatory supports was much lower than in the ARDS picture seen in adults. So the management, as this condition hasn't really been well characterized and has been done on a case-by-case basis, has been mixed with supportive care only for some children who have recovered, IVIG, corticosteroids, and in more severe cases, anakinra and infliximab, depending on their clinical phenotype. But just to stress once more, like with last week's Grand Round, this is really a multidisciplinary case management involving multiple specialties across the trust, including CATS, PICU, general peds, cardiology, pharmacy, immunology, microbiology, rheumatology, and laboratory medicine, and more. So the case definition we created for surveillance purposes and to inform research studies is here. I won't read it out in detail, but it is available on the RCPCH website in the guidance presented there. But the consistent features to look out for are persistent fever, inflammation with very high inflammatory markers, shock, unexplained by other causes, cardiac involvement, gastrointestinal involvement. There has to be the absence of another bacteria or virus that would cause that presentation. As I said before, your PCR for SARS-CoV-2 can be positive or negative. And some of you may have seen the rapid publication from the Evelina group that came out with their first 9 cases from their PICU. And subsequent to this, in networks, including colleagues from Spain, Italy, and France, have seen this phenomenon emerging with varying phenotypes according to location. And also now in New York, there are rising numbers of cases being observed. And as you're probably aware, these are all centers where there's been higher rates of SARS-CoV-2 compared to the rest of the world. So what's going on? Well, we don't really know, but we are hypothesizing at the moment that if this condition is related to SARS-CoV-2 in the majority of patients, then this is the late phase inflammatory response to the virus rather than direct viral effects themselves. And this is what has been observed in adult COVID disease. But we're yet to define how similar or different it is to other conditions we're more familiar with, such as Kawasaki disease or toxic shock syndrome. But in a preliminary look, comparing the blood parameters and clinical parameters with conditions such as Kawasaki disease, it does seem to be very different from Kawasaki disease and a separate entity. There's guidance available on the RCPCH website, and I'd encourage you all to take a look at that if you're interested, for both management of COVID and also PIMS-TS, as we are currently referring to it. So we've got a lot of questions still. We're 2.5 weeks in, so there's a lot to think about. What is the true link to SARS-CoV-2, and is it present in all as a precursor to all cases? Why isn't this just viral sepsis? Which is an important question, but we can't find PCR positivity in a predominant number of patients, and they don't seem to deteriorate on immunosuppression, which you would expect if this was mainly viral driven. We don't really know how best to manage these children and how to risk stratify. We have to make sure we're not missing any differentials like malignancy or other bacterial infections. And we don't know really what the outcomes are going to be, especially on the cardiac side of things. And we are just trying to work out how to follow up all of these children. So what's next? We have an interim management guidance, which we're drafting with multiple specialties across the UK and networks, including the pediatric intensive care networks. With a surveillance study, you may have had an email in your inbox just about an hour ago for a BPSU survey across the country to look at the true extent of this condition. And we're going to be recruiting into observational studies and treatment trials, which Mark Peters will introduce you to later in the grand round. And we're working on an international registry with the Imperial team to try and capture global data hand in hand with WHO efforts to do this as well. So I think I'll finish there, but just to highlight that multiple teams and specialties and networks have worked amazingly over the last 2.5 weeks to work rapidly to characterize this condition further and set research wheels in motion. So thanks to all of those teams, and also to Liz Whitaker from St Mary's, whose slides I've borrowed for some of this talk. So I'll now hand over to May Johnson, who will give you our PICU experience of both COVID and this newly emerging described condition.
So thank you very much, Alistair, and thank you very much for the ID team for asking me to present today. And I am presenting the PICU experience of PIMS-TS. So an overview of my talk, I'm going to talk about the evolution of Dolphin ward, our first case of SARS-CoV-2, and then go on to discuss our first case until May the 7th, and then talk a little bit about our current situation and plans. So on the 20th of March, PICU agreed the Dolphin ward admission criteria. Any child suspected of COVID-19 would be admitted to Dolphin ward and screened, and if confirmed positive, would be cohorted on Dolphin, and if confirmed negative, would be transferred to the appropriate unit. A COVID-19 patient who was suspected was one who had respiratory symptoms or fever at presentation. So by the 12th of April, as a group on PICU, we start to recognize a pattern. We're seeing increasing number of children presenting with septic shock. The phenotype is changing from the respiratory ARDS that is well seen in adults to toxic shock. The overarching link is systemic hyperinflammation. And of note, not all this group were NPA positive. And with that in mind, on the 22nd of April, a new Dolphin ward admission criteria was agreed. So patients would be admitted to Dolphin ward and screened if suspected for COVID-19. If they were positive, they would be cohorted on Dolphin. And if they were negative, but there was a clinical suspicion of COVID-19, they would remain on Dolphin ward. And if they looked like a duck and they quacked like a duck, we would treat them as ducks, cohorting them alongside our other patients. Going back to what Alistair also talked about, on the 26th of April, PICS put out an urgent alert along with NHS England about children presenting with a hyperinflammatory state, possibly related to infection with SARS-CoV-2. And with that, the media ran with numerous articles describing coronavirus-related syndromes in children. And on the 1st of May, the RCPCH statement was put out for PIMS-DS with a case definition of a child presenting with a persistent fever, inflammation and neutrophilia, elevated CRP and lymphopenia, and evidence of single or multi-organ dysfunction, excluding any other microbial cause, and PCR could be negative for SARS-CoV-2 or positive. And so our data that we have collected on Dolphin from the 20th of March to the 7th of May, 239 patients have been admitted to the ICUs across Great Ormond Street Hospital, 66 children to Dolphin, 22 have been treated as clinically suspected, 28 are negative, 16 have tested positive, 3 have had a very classic respiratory ARDS phenotype, 3 have been incidental findings. The 66 definition by the RCPCH. 8 of those have tested positive for MPA at some point during their PICU admission, and 6 tested positive on serology, although had negative MPAs throughout their stay. To give you an idea of the patient characteristics, the median age is 9.7 years. The gender split, 57% male. And of particular note, Black, Asian, and minority ethnic groups form 91% of this cohort. The PIMS, or the predicted mortality at admission, the median score is 3%. Coexisting disorders, nearly 50% of the children that we have cared for have had a weight above the 91st centile. Few have had chronic conditions. And if we then compare our primary presenting symptoms with the RCPCH case definition, 100% of our children have persistent fever above 38.5, 70% have abdominal pain, 61% have diarrhea, 40% have a rash at presentation, and 65% vomiting. The duration of symptoms pre-admission, the median number of days is 5, with an interquartile range of 3 to 7. If we then particularly focus at hemodynamic compromise at presentation, 87% of children have shock at presentation requiring fluid boluses. 70% have refractory shock, and by refractory shock we mean those who need vasopressors. 60% are mechanically ventilated, and 1 requires VA ECMO. This is just to give you an overview of the laboratory data at ICU admission and some of the scores that we're seeing to show how high the ferritin is at presentation, how lymphopenic the children are, how raised their D-dimers are, how markedly high their CRP count is, and you can also see here that their troponins are also raised. Oops. If we look at our outcomes, the median length of stay is 3 days. We have discharged, as of the 7th of May, 21 patients, so 91% have been discharged. In ICU and hospital survivors, 100%. Our actual mortality so far, 0. And this brings us to the present. So our current plan is to try and work together as a team to look at a COVID score, a clinical score to confirm the diagnosis, and importantly, a score that might be able to predict disease severity, and by that, length of stay on ICU. And we will hopefully put this together using the clinical variables described. And here we are, and this is where our journey so far has taken us, to an MDT, an established trust pathway for children being admitted to Great Ormond Street Hospital with SARS-CoV-2 infection. And thank you very much. I would like to now hand over to Kimberly.
Okay, thank you very much, May. And I'm just going to share my screen now. So we're moving from the clinical perspective to laboratory investigations. And in particular, I'm going to spend a couple of minutes focusing on COVID serology and what that is. Just to remind everyone, this is an antibody test which measures production of immunoglobulin in response to infection. This is not the PCR-based antigen test. The PCR-based antigen test says that you have COVID at this instant. The antibody test simply says that you've come into contact with COVID in the past. If it's positive, it indicates exposure to COVID. It's still really important that people, particularly staff who know they're positive, still wear their appropriate PPE. And in particular, we have no idea at the moment if these antibodies provide immunity or not. So it's very important to continue appropriate safety measures. A negative result doesn't exclude COVID because we know that antibodies can take up to 21 days to develop, and certainly based on other viruses, they're not positive in all patients. But deciding that we wanted to develop a COVID serology assay, we looked at two things. We looked at the flow cells, which is what the government was advertising and may or may not have bought 3 million of. And the ones we looked at and some other centers looked at were very specific. If they were positive, you certainly had COVID antibodies, but they weren't very sensitive. We had lots of patients that we knew had COVID because they were PCR positive that were coming up negative on the flow cells. So that wasn't a very useful test for us. So instead, we looked at an ELISA, which is a test that we thought would have reasonable sensitivity and specificity. So the first thing we have to do with any new test in any laboratory is we have to validate the test. And for this, we looked at PCR positive patients and looked at their serology. And what you can see here is that patients who are PCR positive, for the most part, had good antibodies to COVID. We also tested 52 samples that should not have COVID because they were collected before December 2019, and of those 50 were negative. So that what that means is that a very small percentage of samples are testing positive on this assay despite having never seen COVID. And that allows us to calculate how the test performs. So this test has a 92% sensitivity. That means 92% of the time at day 14 after infection, we identify antibodies in patients that we know had COVID by PCR. Its specificity is 96%. What that means is about 4% of the time, the test may give us a false positive reading. It may suggest someone's had COVID who hasn't really. We suspect, but don't have evidence, that those may be in patients with very high immunoglobulin levels, and it may be a non-specific finding. We also wanted to make sure the assay repeats. So if we run the same sample on the same plate or on different assays, plates, we get similar results, and that's very important for a robust assay. One of the things we looked at was the amount of antibody measured by an optical density and the amount of PCR versus the PCR results. And what you can see is that patients who are PCR positive have high levels of antibody, and very few patients who are PCR negative had much antibody. And these may have actually had COVID, we don't know. Because they may, the PCR is only sensitive usually in the first week of infection. So these may not have been optimal time points, but clearly you can see if you're PCR positive, you have relatively high levels of antibodies. As part of the validation, we looked at some asymptomatic healthcare workers, and when we did that, and this was a couple of weeks ago, it was about 4 weeks ago, we found that about 34% of those were positive for antibodies. It's at a time when the trust had a fair bit of COVID circulating, and it suggested that a significant number of staff may have had COVID without symptoms, and that's led to a study that Louis is going to talk about called CoSTARS. What's interesting and very preliminary data within CoSTARS is of the first 377 samples tested, 15% had antibodies. COVID serology is important not just for staff in determining who may or may not have been exposed to COVID, but much more importantly for patients. And this was particularly demonstrated by May's talk, where a number of children have had negative PCR tests, and this is also true in the adult situation, but they are positive for COVID antibodies. We don't think this is related to replacement immunoglobulin, because we've tested a series, thanks to Dolphin sending up the empty bottles of immunoglobulin here at Gosh, and Birmingham has done the same. And of the 4 different brands of immunoglobulin we've tested to date, all have been negative for COVID antibodies. So we don't think it's from the replacement immunoglobulin that we're seeing COVID positivity, COVID antibodies. But what this does suggest in these patients is that they had COVID, and it implicates COVID in the new disease, PIMS-TS. Obviously, this was a huge amount of work by a number of people, both here at Great Ormond Street, and we've been working with Wales and Public Health Wales, and Sarah Beckett-Hartland shared her data of all the immunoglobulin batches she had tested. And obviously, this work can't be done without the amazing staff in the immunology and virology departments here at Great Ormond Street, because it's a huge amount of work to develop these assays, and we developed them amazingly quickly. within 3 weeks, and then running these assays. So now I'd like to hand over to Louis, who I believe is going to talk about the COSTAR study.
Thanks very much, Kimberly. Just share my desktop. Okay, so and thanks very much, Jonathan, for giving me the chance to chat today about the COSTAR study, which I'm really pleased to have been involved with over the last few weeks. Just a bit of background, first of all. We know already from studies that were taking place in New York with cohorts of patients that it's possible to be reinfected with seasonal coronavirus. That's the coronavirus that was circulating and has been circulating for some time prior to this pandemic within 1 year. It's also possible to get reinfected, or it's possible to your antibodies to SARS and MERS are known to wane over the period of 5 years. So this background information is really important and kind of made it worthwhile doing the study and trying to interpret how long our antibodies will remain detectable for following infection or exposure with SARS-CoV-2. So what are our primary research questions? Well, we want to know how long the antibodies remain detectable for. We also want to try and know what level of antibodies we require for protection. Nobody knows that. We want to know if reinfection is indeed possible with SARS-CoV-2, which is unknown at present. We want to know what the prevalence of infection and exposure with SARS-CoV-2 is at GOSH. And as Kimberly has alluded to already, it looks so far to be around 15 to 20% of staff in our first cohort are coming up positive. In the future, we're also wanting to be looking at the cell-mediated immunity to COVID. That may be 50% of the equation here, the importance, and so ongoing studies will focus on that. And then we wonder whether actually severe disease is associated with higher and longer lasting titers of antibodies, which is something that we can find out. So the structure of this study is a 2-arm prospective cohort study in which we're trying to recruit as many people as we can across the trust. Please bear with us on this, because I think within the first couple of days of recruitment, all the slots over a 2-week period filled up. So we're aware of that, and the operational side of GOSH are working on that to try and open the study to more people. The aim is that we'll follow up people who are seropositive every 1 month to 2 months to see what happens to their titers, and then also follow up the seronegatives every 6 months to see if they seroconvert in that time. We've aimed at the outset for 1,250 patients, but within about 7 days of running the study, we're already up to 800. And so we expect we're going to go far beyond that. We're looking at antibodies to the nuclear capsid protein. If it's fully funded, and we're applying for grant money now, the study will run for 6 years. So we hope to see you all back again to measure your antibodies. It's already been approved by the Health Research Authority and has been registered on clinicaltrials.gov. So with that, I'll hand over to Prof. Mark Peters, who can tell you all about his research studies.
Thanks, Louis. So I just want to reassure everybody that we are going to, if it loads, learn about these kids as we go. So it's not just, there we go. So some of you may be aware we have a program of pragmatic clinical trials on the ICU. We were happily proceeding through doing those when the pandemic came, and that just had to stop up our research activity dead on those trials. But it, rather than have the time off, what it did was require us to jump across to a set of studies that were identified as being on something called the Urgent Public Health Priority List. And it was a massive effort, especially by Lauren, who leads our research nursing team on the ICU, to be agile enough to go from the stuff we did to a collection of new studies that were all brand new and under real time pressure. And you'll appreciate that it takes a while to set up studies normally. So the ones that got going first were those that were had a sort of prior history. So the first of those is something called ISARIC, which had its roots in the 2009 flu pandemic. And this was kind of a sleeping study that was ready to go to do some clinical and laboratory phenotyping of emerging severe acute respiratory infections. And our local PIs are Drs. Mock and Bamford. And we recorded recruited a number of patients, 37 across, I think, the current correct number across the US. It's not just the ICU, it's on the wards as well. So if you have a patient of yours who is known or strongly suspected to be affected with the virus, we're likely to approach you to include in this study, and that will be important to have your support to do that. Just to give you a scale of what was achieved from ISARIC, this is already a week old, these data, but they have nearly 30,000 patients from 30 countries and nearly 300 hospitals. And here's just some outcome data from those by age. And obviously you'll all look for your own age, mine's somewhere in there. So the risk isn't too bad, though worse because I'm male. So that's one of the things that's running. There are also a couple of mechanistic studies, both of which were, again, existing in other forms. So genomic, looking at the genetic predispositions to complications on intensive care, and diamonds, which was using RNA molecular signatures to distinguish viral from bacterial infection. Both these existed, but were sort of rather deftly repurposed for looking at COVID in very short order. And these potentially give us, particularly the diamonds study, give us a mechanistic insight to what's going on in PIMS TS if we do finally conclude that it is a different condition. But all of those are descriptive, and I think what I want to flag up is the only study that started from scratch that we're going to be recruiting to in the next 24 or 48 hours or so, which is something called the recovery trial. And this is an extraordinary undertaking. It's led from Oxford, and it is in all hospitalised patients with COVID, so you don't have to be on the ICU. But it's something called an adaptive platform design, where it looks simultaneously at multiple different domains. And here there are antiviral, anti-inflammatory, whatever chloroquine's supposed to do, and azithromycin, all as options that can simultaneously be randomised in an individual patient. And what's striking about this is almost 10,000 COVID adults have been randomised to this study in the last 6 to 7 weeks, which is a fantastic achievement. And the paediatric arm has just opened this week, and we should be recruiting. The sort of double tragedy of this sort of disease would be that lots of people get sick and a number die. But if we don't learn from the process by including patients in formal randomised trials, we're going to suffer the same fate in the second wave. So here's where we are. This is the recovery study, and I can now pass on to Joe, who's going to talk to us. Joe Standing, who's a reader in pharmacology, who's going to talk to us about an upcoming antiviral study that they're planning.
Thank you. So along with Judy Brewer, our group has looked at a meta-analysis of viral loads with time in the literature. So we've got data on about 300 patients so far. And whilst most patients are not viremic, we do find the virus in various places like ocular secretions and in the stool, and of course in the respiratory tract. And in a non-intubated patient, the most reliable place to find the virus is indeed in the saliva and the throat. Now, regardless of where you find the virus, it does seem to follow this characteristic pattern where on the day of symptom onset, you already have quite a high viral load, and the viral load then peaks 3 to 5 days later and falls again. Patients with severe disease will have a higher peak and possibly a shallower decline, but regardless, after about 5 days, viral load starts to decline in pretty much everyone. Now, in terms of antiviral options, antivirals don't kill circulating virions. They interrupt intracellular viral replication, and sometimes they stop virus getting into the cell in the first place. So as you can see, if we start treatment when we're on this downswing, after viral replication is slowing down, antivirals are expected to have fairly limited effect. So we need to start antivirals really in the first 3 to 5 days of symptoms. Now, of course, we're not going to recruit children to this kind of study because most children won't progress on to severe disease. So the FLARE study is aimed at healthcare workers, and GOSH staff will be eligible to be recruited. We've chosen to use 2 antivirals. The first one, and the one we have the most hope for, is favipiravir, which is a drug we've got experience with at GOSH and at Royal Free, where Dave Lowe works. And it's essentially the oral remdesivir. It doesn't have to be given IV. 100% bioavailability, not very protein bound. However, it's not quite as potent as remdesivir, and we think favipiravir alone may not give us enough antiviral effects. So we're choosing to partner it with lopinavir, antiretroviral, that acts at the stage prior to favipiravir in the viral replication cycle. So we're hoping for at least additivity, if not synergy. FLAIR is a 2x2 factorial design study. So people will be randomized to placebo, either drug alone or both drugs together. So if you enter the trial, you've got a 3 in 4 chance of getting an active drug. And we only had confirmed funding last week, so we still have to go through the expedited MHRA approvals and everything. So it's going to be another 6 weeks before we can open the trial. But please, in the next 4 to 6 weeks, look out for publicity, because we will be recruiting healthcare workers, and GOSH staff will be eligible. So with that, I'd like to pass you back to Karen.
Thank you so much, Joe, and thank you everybody for speaking. We look forward to returning to you all in the future with the results and the conclusions of those studies, hopefully with a great deal of success to report. Before I hand over to Jonathan, just 2 things. We talked about different staff who are responsible for caring for our patients and how hard they are working. The one group of staff who remain very unsung, who I would like to say a big thank you to while we have so many people online, are our cleaning staff, on whom we are very, very heavily reliant to keep the environment within which we work safe. So thank you to all of them. I'm not sure how many of them would be online, but please will you remember to say a special thank you when you see them. The other thing is that BPSU, as Alistair said, is starting a surveillance study. We can't obviously all be reporting the same patients. So the infectious disease general pediatricians and ID teams will be reporting those patients for you, as between us, we will see all of them. If you are unsure and you have a patient and you don't know if that patient has been reported, please ask one of those teams. So thank you very much. And I'm going to ask all the panelists to please restart their videos and hand over to Jonathan to start the panel question and answer discussion.
Great. Thank you very much, Karen, and all the speakers. I've had some feedback via text message and on Slido saying that everyone thinks this is a very high standard of presentation, and fantastic group of colleagues we have at Great Ormond Street. It's very informative. Thank you. So there's been a few questions about the PIMS TS itself. Is there any similar or equivalent sort of post-viral hyperinflammatory syndrome that you would see normally in times when there is a high viral load in children?
Thank you for that question. I mentioned the possibility of this being a viral sepsis type illness, and there are conditions such as HSV or herpes simplex virus, where we can see very severe critical acute illness with a similar phenotype. Also, in relation to enterovirus, we can see quite severe sepsis, especially in younger children. And also related to flu and the complications of flu, we can see this level of critical illness. But I would stress with examples such as HSV and enterovirus, we do usually detect those viruses in multiple compartments during the illness. So there does seem to me to be something slightly different about this in a post-infectious way. There are lots of inflammatory conditions that we observe that may have a viral trigger. And it's well known that the conditions such as Kawasaki disease may be associated with many different viral triggers that are common childhood viral illnesses that would be the spark to the flame of the inflammation that you observe. But for me, I'm not aware. Maybe dengue has a sort of similar sort of phenotype. The second time you're exposed to get a very inflamed response. But I can't think of anything else from the top of my head that is similar to this yet.
Okay, so it sounds relatively specific. And I think people are thinking about, are the children that have this actually infectious by the time they get this hyperinflation or inflammatory response to it?
That's a $60 million question. It's quite difficult to find virus in a large number of these children, as you saw from May's presentation, and perhaps Kimberly can speak to this from a testing point of view, but a number of those children will not have positive NPAs, but will have positive serology. We err on the side of caution and treat all of them as if they were infectious, because they might be shedding virus from other sources, such as stool, and might continue to be shedding virus below the level of our detection of our particular test. So we need to continue to be vigilant in using proper PPE and infection prevention and control procedures. But we are at this point.
So, Karen, I think you muted yourself inadvertently there.
Oh, sorry. Perhaps May and Kimberly would like to comment on those 2 points.
We know from a lab testing point of view that the assay has a limited sensitivity, so that if the viral load, and we know this for all viruses, if it gets too low, you can't PCR it up anymore. And we know because of the way it travels, it often starts in the nose and throat, but then ends up in the lungs. So you might not find it if you didn't do something like a bowel sample. So it's hard. I think they probably mostly don't have a lot of circulating virus in a lot of sites, but unless you're going to test every single site, you can't really know that. So as Karen said, it's really important to use appropriate PPE and things. I don't know if May wants to say anything else, or Jim?
I was just going to say that that as we also use immunomodulatory drugs, we don't know what effect that will be to the viral shedding as well. So we are, as we evolve in our knowledge over the last few weeks, going to take a very precautionary approach to the step down of our IPC precautions in these kids.
We've had a question about the immunomodulatory drugs. I mean, what about the monoclonal antibody therapy agents that act on IL-6 and TNF and those that we use in the children with inflammatory diseases? Could they be used for this sort of thing?
That are being used for this sort of thing, and perhaps May would comment on the clinical response of the PICU patients to those drugs.
Perhaps I could just come in before, if that's okay. So I only showed you the platform study is actually more complicated than I had time to display. There is a second tier randomization that includes immunomodulatory treatment, though only with the anti-IL-6 antibody. My view is I'm actually much more skeptical than the other speakers about whether to say this isn't viral sepsis. I think this is a group of patients at one end may have, if you like, over-responded and still have hyperinflammation in the absence of a cause, but a proportion of them are still positive. So I think there's potentially a continuity between acute infection and severe response that's appropriate to a disproportionate response. So the consequence of the reason I'm raising that now is I don't think we should be using experimental anti-inflammatory therapies outside the structure of a randomized clinical trial. I'm not sure everybody will agree with me, but that's just, I think otherwise we'll be back here in a few months' time when there's a second surge and we'll be guessing again. So I'm keen, and the platform study is specifically designed to address that uncertainty, and it has a set of characteristics that it's comfortable to include the PIMS-TS cases in, although it concedes that you're probably going to give immunoglobulin plus or minus aspirin before then.
May, and then perhaps Louis or Alistair, you'd like to comment on that and respond to that.
I think which would be nice, and actually if time had permitted today, we could have tried to present some of the children and actually their case histories who've had what we could describe as the classic PIMS-TS group, and look at them, and actually the ones who have had treatment, particularly with the IVIGs, appear to have a very quick recovery. And potentially as we get more data, we could come back and try and present that to you as a group, and we could look at that in more detail.
I was just going to say, Karen, that in response to Mark's point, that obviously we want to include all of our children in trials if they're available. And thankfully, Recovery Trial has been brought online for kids, which is brilliant. So now we can start doing that. But obviously, at the same time, if we see someone presenting with Kawasaki disease, which we know how to treat, we're going to, or features very similar to, we're going to kind of get on and treat that, as it were. The thing is, these cases are kind of grey cases which don't fulfil all the criteria. So we have to, until we can get them into trials, we have to sort of, make MDT decisions on the hoof. But so far so good with these patients. Thankfully, that whatever we've done, they've been improving, which is, I hope that continues. Good.
And there's always a couple of questions about testing. I mean, one thing that Joe did mention, and I think Prof. Brewer mentioned at the beginning as well, that you get a very high viral load in saliva. So why are we doing MPAs and not saliva tests on staff and people in general? And once people are intubated, should we be doing BALs rather than MPAs? So if there's a higher viral load down in the distal airways.
Jim, Louis, Kimberly, perhaps in that order.
So in regard to saliva, it's a very good question because we're looking at exactly that, and we're looking to validate some saliva kits for that exact reason. It's also a very attractive sample to take in mass testing, as we were all talking about that nationally. And in regard to NPA and BAL, absolutely, as this travels down from the nasopharynx down into the lungs, BALs are a very good sample for that. There's actually the logistics of taking BALs in some of these patients as well, which probably May or the PICU team could comment on.
I was just going to say that's a really good point about the saliva, and actually we're actively looking at that. There's a senior lecturer called Claire Smith at ICH who was already put in a grant to GOSH charity to support that. So I look forward to recruiting all of my colleagues and watching them spit into a pot so that we can look at measure their corona IgA over the next few weeks.
I should say, so IgA and saliva, but we're also, as Jim mentioned, testing the ability to do PCR, so antigen testing out of salivary samples. Ideally not spitting, because we think that might have some infection control risks, but using some lovely swabs that you swab back and forth for a minute and then PCR those. So we're trying to validate that, and obviously if we could, that would be a much more attractive way to sample both our patients and staff.
And just from an ITU perspective, we have done a number of BALs on patients, but again, in terms of infection control risk and reducing exposure to our staff, it's been something that we've been actively trying not to do in many of the patients.
Okay, good. A couple of questions about sort of the wider impacts it has on society. And do you think this is going to raising this is an issue in the wider public is going to delay getting our children back to school? And is there any comments about why you think that 91% of your patients come from an ethnic background?
Hopefully it won't delay children getting back to school. This is a very, very small number of children. The problem is we don't know how many children have actually had COVID-19 asymptomatically, which would give us some idea of how common or how rare, which it actually is, which I think would be a huge comfort to the wider society. I think that, we're just going to have to watch and see. We're in somewhat uncharted territory in terms of the number of children who come from Black and ethnic minority groups. Again, you have to be very cautious about drawing conclusions because they come from communities where there is a high number of Black and Asian minority ethnic groups. And also we don't know whether those were areas which were particular hotspots for COVID-19, and therefore the general population, there were far greater number of people who were infected in that population than perhaps in other areas. So we need to be cautious, but we also need to be aware and look at that more closely. I don't know if Louis and Alistair would like to comment on that in that order.
Yeah, just one thing that we've got the opportunity to look at is triomes of genomes, and because we've seen 2 of these PIMS-TS patients present who have consanguineous parents, so we're just sending off their exome sequences to Exeter, who are doing whole family exome sequences. So maybe over the next couple of weeks we'll have some sort of underlying genetic association with these. It'll be interesting to see.
I would just echo what Karen said. This is just really stress that the data we have so far is on a very small population in the London region. And so we really need to look at the results of the BPSU survey to work out whether there is an ethnicity signal within the data.
Thank you very much. And I think I'm just conscious of time. I'm taking up all your time, and we're nearly an hour into this now, and we're losing participants. But just one last question. And I think that you're talking about giving antivirals very early on might alter the course of the disease. And would there be a case for giving pre-exposure prophylaxis to staff members that are performing aerosol generating procedures, or maybe at very high risk? Because that seems to be working in other populations to prevent viral transmission.
Joe, do you want to comment on that?
I think the big problem with pre-exposure prophylaxis is which drugs are you going to use. So, people are using chloroquine and hydroxychloroquine, which is never going to work. You know, the antiviral properties of these drugs have been known since the 1980s. They've been tried against every virus going and never worked in the clinic. There's been huge prophylaxis studies in influenza and they've never worked, even in some really high quality placebo-controlled trials. So I think, you know, the sort of mass health worker prophylaxis trials on hydroxychloroquine, you know, it's never going to work. But I'll wait to be proved wrong on that. In terms of if you've just been exposed to an aerosol generating procedure without the correct PPE and you feel like you want something in the way needle stick type thing, potentially there could be a role for that. Perhaps using, you know, more sensible antivirals, but I'm not aware of any trials doing that at the moment, and that's not a design that we're doing in Flare, but potentially that's something that could be useful.
Okay, thank you. That's very interesting. Sadly, I think that's all we have time for at the moment. And would you be happy if we got any questions through PGME that we could forward them on to you to be answered directly, or put them onto the PGME website as a panel?
Sure, I think I can speak for the panel that they'll be happy to.
Great, yeah, that's the right answer. Thank you very much. Good. Okay, look, all I can say now is thank you very much to the panel. I'm going to wrap up now. And Karen, Alistair, May, Kimberly, Louis, Mark, and Joe, that's fantastic from your point of view. Very informative, and thank you for answering the questions so clearly. I'm going to wrap up the grand round from this point of view. We're going to be back next Wednesday, and our CAMS colleagues are going to talk about the mental health effects that the COVID pandemic has had on the children that we're treating at Great Ormond Street Hospital. You can see that same time, 1 o'clock until 1:45, 2 o'clock on Wednesday, the 20th of May. And please fill out the feedback forms so you can inform us to how we can improve the grand rounds and keep them going over the next few weeks. Any subjects you want to hear about, please let us know. Anybody that would like to present on a grand round, please let us know. And we're very happy to include you in that point of view. And as we say, if you want to get CBD improvement points from RCPCH, you can self-credit your CBD points for 1 point, and we'll happily send you an attendance certificate if you'd like. But I think that's my time up. And thank you very much to everybody, and we'll see you next week.